Welcome to Eye Contact, a video news program on issues and controversies in ophthalmology sponsored by EUROTIMES. I'm Oliver Findl. We're here at the XXXIII Congress of the ESCRS in London. Not long ago, the idea of sequential bilateral cataract surgery was considered to be too risky to even think about. But the tide has turned as more studies support the safety of this approach, not to mention its economics benefits. Today we're speaking with Dr. Steve Arshinoff of Toronto, Ontario, Canada, about the state of immediate sequential bilateral cataract surgery. So thank you for coming, Steve.
Thank you, Oliver.
Just give me the terminology. What is, immediate sequential bilateral cataract surgery?
Okay, we had difficulty in deciding on the terminology because everyone who was doing bilateral surgery used different terminology. And eventually it was the Swedes who proposed to us English terminology. So we ended up with immediately sequential bilateral cataract surgery for 2 procedures done the same day, delayed sequential bilateral surgery for 2 procedures on the same person done on separate days, like a week apart, and unilateral surgery for only 1 procedure done. They only have 1 eye, or whatever the case may be. The confusing thing is the society we had, the International Society of Bilateral Cataract Surgeons, started and was named before we had terminology. And the letters are exactly the same as the procedure. So we have a small italicized I for the society now.
Okay. So how did you get started yourself?
Well, like all of us, we were taught as residents not to do ever bilateral surgery or anything bilateral. And so I was afraid to do it. But as we went along in the early 90s, surgery got safer and safer, and my complication rate went down as we got better machines and we used OVDs better and whatever, like all of us. And one day, in walked this beautiful 45-year-old young lady who sat in my chair, and she had bilateral cataracts and told me that she's a racing car driver, which that surprised me. And she races cars in summer in the United States, and in winter she tests Toyotas in the north of Canada because we have a lot of snow. And she said, I only have 3 weeks in between, so I'm not going to have 2 operations. Either you do it, because she heard that I was a good surgeon, or I'm going somewhere else. I'm accustomed to risk. What do you want to do? So I said, okay, we'll do it. So we did her procedures, and on day 1 post-op, she was 20/20 in each eye, and she was perfectly happy, and she really was walking around my office telling the other patients to have bilateral surgery. And so then, some other patients wanted it, and we began to do a few. And they just kept getting better and better as we, slowly evolved protocols and procedures for doing bilateral surgery.
I mean, what is the studies that back up the safety of this kind of surgery?
Well, I did the first study we published in, I think, 2003, looking at our first 2,000 or 3,000 patients. And we looked at them, and we really had no bilateral complications. We're always afraid that something that happens in the first eye will happen in the second eye. Well, firstly, we were so nervous and cautious in the beginning. We had no complications because we would just not do bilateral surgery in mature cataracts, diabetics, the whole list we all look at. So we really had no complications, or very few, and none that were bilateral or referenced to be a high risk for doing bilateral surgery. So we published that. And then, as our society got going, we did a study asking all the doctors in the group to contribute their data to look and see what the infection rate was.
It's like a registry.
Yeah. And so we collected about 102,000, 103,000 eyes, and the incidence of infection, admittedly it's an elite group of surgeons because no one else does bilateral surgery, the infection rate was between 1 in 15,000 and 1 in 17,000, depending how you counted and whose you sort of count here and there. And so we had a really, really low infection rate, much lower than the ESCRS study. If you look at the literature now, the newer studies coming out are showing 1 in 5, 1 in 6, 1 in 7,000, gradually getting better. And we think that our risk was low because we were using intracameral antibiotics. People who do this adopt these procedures quickly because they're nervous. And so we had a very, very low infection rate. And we did the math looking at a bilateral infection, the risk of bilateral simultaneous endophthalmitis. And even if you assume that there is a linkage, suppose you assume triple the rate for the second eye, you still get a risk of 1 in 100 million for having bilateral simultaneous infections. The risk of being hit by lightning is higher. The risk of dying in a car accident driving to your doctor's office is higher. The risk of dying from general anesthesia is 2,000 times higher. So we thought, well, it's not a really serious risk.
But what about toxic anterior segment syndrome? This is something which rarely happens, but if it happens, typically will infect a whole operating list and several patients on one day. What
Yes.
do you do to prevent that or avoid that?
We discussed that, and our policies are that we advise everyone who wants to do bilateral surgery to do, are to be comfortable with what you have. First, make sure you haven't had any recent problems like that. And then before anything, no matter what, is changed in your operating room, that the whole team gets together and discusses it. The nurses, the doctors, the pharmacists, where your drugs come from, if you're changing your gloves. There have been tasks reported from gloves, from all kinds of things. But it's almost always from changing something that's found to be the cause. So far, there hasn't been a single case reported of tasks from bilateral surgery. And maybe that's why, but it appears that by being cautious and not going and buying new anything, unless we check that it's okay, or call somebody who's used it for 20,000 cases, we've been okay.
And what about another thing? I mean, when we look at the first eye, when we're doing second eye surgery, typically I'll have a look at the refraction of the first eye, and we'll sort of change the IOL power in quite a few cases, maybe for half a diopter accordingly. There is a nice study by Thomas Olsen, you may know, from 2 years ago on several thousand eyes, showing that if you adapt the IOL power of your second eye according to the refraction of the first eye, you actually get better outcomes for your second eye. So you can enhance the IOL power calculation. Is that an issue which...
Well, there have actually been 6 studies, and I'll reference Thomas Olsen's study because it's the best one. And if you look at his study very carefully, he then took those patients and he compartmentalized them into which equations were being used and which methods for biometry for different patients. And it turns out that the risk of having an error that you can actually repair in the second eye that's large enough to be significant enough to change the lens keeps going down as you go to better and better biometric methods. And so if we tried the SRK2 equation, he had like 0.06 or something errors, and SRKT 0.02, and the Olsen equation with LensStar, he had vanishingly small errors. So I think it's something that we would do if we don't have very good biometry. But as we get better and better biometry, and most people who do bilateral cataract surgery are kind of sticklers in making sure biometry is good, it just isn't an issue. And I just finished doing my 9,000th case, and I think I've changed 2 or 3 lenses, but they were all in the beginning when we were doing ultrasound and before we had any of the new machines and new equations. And they were all like high pros, ones we knew could be off, and some of them were. But since then, I've had no one who had an IOL exchange in the last 5,000 eyes or 6,000 eyes.
Well, thank you very much for sharing that information with us, Steve.
Thank you for having me. It's a pleasure to be here. It's interesting that the opposition to bilateral surgery seems to have evaporated in the last year. We had 2 debates, one at the ESCRS and one here. And in both of them, there really wasn't any opposition. The other side more or less agreed, just saying they want to be careful and had some concerns in getting going. We all have those concerns in getting started, making sure we're careful.
Thank you.
Thank you, Oliver.
Thank you for joining us. For more information on this and related topics, please visit us on EUROTIMES.org.